In contrast with Richard Dorflinger, David Watts and Timothy Howell provide reasons to allow physician-assisted suicide. First, we need to consider terminology and distinctions. This is an important part of their argument. And Watts and Howell distinguish carefully between physician-assisted suicide, or what I often will call PAS, and voluntary active euthanasia, or VAE. And these two things are often confused or often treated as synonymous. And so we need to be careful in terms of what we mean if we're talking about allowing physician-assisted suicide. Watts and Howell do not want to allow voluntary active euthanasia, so obviously they need to be distinguished from one another. And the American Medical Association clearly distinguishes between the two, so they argue that ethicists should as well. And the definition of voluntary active euthanasia is that it is the administration of medications or other interventions intended to cause death at the patient's request. In contrast, physician-assisted suicide is the provision of information, means, or assistance by which a patient may take their own life. Those two definitions are fairly important, and we want to make sure that we distinguish between the two. So when we say, for example, with physician-assisted suicide that the physician may provide information, maybe that would mean providing information about toxicology, what harm might be done if a substance is ingested or injected, or pharmacology for particular medications, what a lethal dose might be, for example. Or they may be providing the means for the patient to commit suicide by giving a prescription for a lethal amount of medication. Or they might more directly assist so that they would, for example, start an IV and set up the lethal drug, but then have the individual themselves push the button or pull the tube clamp so that the lethal drug would be administered. Okay, so summing up the terminology, the previous definition is the one you should focus on, but we could think about it slightly different way here. Physician-assisted suicide, in that case, the person is committing suicide. So keep that in mind. The S in the PAS is suicide, but is assisted by a physician, and that might be by providing information, a prescription, inserting an IV, or other kinds of means that are short of actively killing the person. The person themselves is taking the step for the death to occur. In contrast with euthanasia, let's think about the meaning of the term here. The literal meaning, or the roots for the meaning, the Greek words youth part means good, and the thanos part means death. And so literally, it is a good death. The idea is that it would be a controlled death that is intended as an act of mercy, or otherwise for the benefit of one who's dying. And there are two pairs of classifications that might apply to a situation of euthanasia. On the one hand, it could be voluntary. So the person requests to die, and then somebody does an action so that the person dies. On the other hand, in contrast to voluntary, it might be involuntary, where the person is not requesting to die. Now, technically, if they cannot request to die, and they are not saying yes or no, for example, it would be non-voluntary. But these, broadly speaking, we've generally called these involuntary. Now, the other pair that might be applied to euthanasia is first active. So there's an initiation by the medical staff or someone else that causes the death. So, for example, an injection of a lethal dose of a drug would be active euthanasia. And then finally, to contrast with active, we have passive euthanasia. And in this case, there's inaction by the medical staff or someone that is known to be likely to result in the death. So a best example might be not initiating life-saving action. So for example, somebody's having a heart attack, the heart stops, they quit breathing, and the people around refrain from performing CPR. It might also include unplugging a life-preserving machine. Now, this is kind of an action, but it's considered passive because it's ceasing the action that's going on. There's not really an action that will cause the death. It's just the removal of the machine, and then either the death occurs or not. So these two pairs could be joined together in different ways. So you could have voluntary active euthanasia, which we've already mentioned, and that is when the person requests to die, and then the medical staff or someone intentionally causes the death. That's what VAE would be. But you could also have involuntary active euthanasia. The person doesn't request it, but somebody initiates an action that causes the death. And likewise, passive might apply to either voluntary or involuntary. So somebody might request that they die, and instead of some action being taken, maybe somebody unplugs a life-preserving machine, or again, does not perform CPR if they're going into cardiac arrest. Or it could be passive and involuntary. Again, that would most likely be a non-voluntary situation, or, again, these things that are done passively. So active and passive might apply to voluntary, and active or passive might apply to involuntary. So, for example, in a movie where people are being infected by a zombie disease, so they're going to turn into a zombie, sometimes you might see a voluntary active euthanasia. The person knows they're infected and they say to someone else, just shoot me, right? Or sometimes it might be an involuntary active euthanasia. The person says, no, I'm going to be okay, but somebody else, intending for the benefit of the person who's infected, goes ahead and shoots them so that they don't become a zombie. So, these things could apply in various contexts, as well as the medical context that we're primarily concerned about. Now, what are the relevance of the terms? Of course, Watts and Howell argue that often the arguments from ethicists against physician-assisted suicide are actually directed against voluntary active euthanasia. So he says that people are sometimes confused over what's going on, and you have to be careful to sort out the arguments and make sure that the proper topic is being discussed. And while they consider VAE as morally impermissible due to arguments similar to what Dorflinger provided, so they have some sympathy for Dorflinger's arguments, and they say, well, those are fairly effective against voluntary active euthanasia. But they argue that physician-assisted suicide is still morally acceptable, even in light of those types of arguments. So primarily their concern is to consider arguments similar to ones that Dorflinger has that are against physician-assisted suicide, or they might claim they're actually against voluntary active euthanasia. And they argue that concerns raised against PAS are overstated, and they shouldn't result in restricting PAS. So the first argument they consider is the concern for abuse of vulnerable persons. We saw this argument very clearly expressed by Dorflinger, and patients may request PAS out of concern for other people so that they are not a burden. either to their children or the caregivers or someone else. And what Watts and Howell argue is, well, that may be a legitimate reason for not allowing voluntary active euthanasia, but they claim it's not a legitimate reason for restricting PAS. With physician-assisted suicide, the ultimate decision and action is going to be up to the patient, not the physician. So they argue that since it's in the patient's hand, this is different, and they're less likely to be vulnerable and go ahead and follow through with this. And culturally mediated requests might still be a concern, or maybe that might request PAS out of fear or pain or depression. And Watts and Howell says that's why it would be important if we allow this. We need to have physicians to be involved with the process, and we need to allow for reversible conditions to be treated. And their responses go on here that the concern for the vulnerable presents, again, a good argument against VAE, but not for PAS. And they cite the Netherlands, where PAS is legal. And they say about 75% of requests for euthanasia are refused. So often the provisions are not provided anyway due to restrictions in the law. Now, the choice lies with the individual, so they argue that societal abuse is less likely, and they argue that these safeguards should be put in place if we legalize PAS, and you would require a persistent, competent request. In other words, the individual requesting the physician-assisted suicide must be doing this over an extended period of time, not just a one-time event where they might be feeling especially depressed or vulnerable that day. And physician assessments are required, as we mentioned, for potential treatment of conditions that might be able to be reversed. So if an individual is suffering a significant illness, but it's something that could be reversed, then in that case, we would not allow physician-assisted suicide. Instead, the treatment of the underlying problem would be the proper procedure going forward. Now, whether or not this succeeds on alleviating the concerns about the psychologically vulnerable and the elderly is up for you to decide. It seems like that with physician-assisted suicide being legal, you would still have these concerns that Dorflinger and those who are skeptical or even against physician-assisted suicide, those concerns seem to still be relevant as much as they would be for VAE. So the safeguards that they talk about seem to be very helpful and might prevent abuse, but they may not fully alleviate the concerns for the vulnerable. So, in any case, they address a second argument, the concern that physician-assisted suicide might undermine the trust between physicians and patients. And they say that, first of all, again, it's another situation where you have to keep in mind this distinction between PAS and VAE. With VAE, again, it's voluntary and active euthanasia, so the killing is done by the physician, but with PAS, since it's a form of suicide, it is not. And they say if VAE is prohibited, that would alleviate worries about misplaced trust of physicians' abuse. Physicians are not actively causing death, in other words. And a concern is that if PAS is legalized, it might negatively affect the societal, the cultural views of the role of physicians, medical staff, and that the trust in medical caregivers might be weakened. But Watts and Howell argue that, in fact, the culture's attitude towards physician-assisted suicide has been changing in the last several decades. And they cite studies that say in 1975, only 41% believed that somebody in great pain and with no hope of improvement had the moral right to commit suicide. But by 1990, that number had increased to 66%. That statistics more recently have, by a Gallup poll, have 75% favoring the right for voluntary active euthanasia, and 67% who say that physicians should be allowed to be involved in assisting people in their suicide. Now, notice this is kind of flipped from what Watts and Howell have been suggesting, that PAS would be allowed and VAE would not be allowed. In fact, according to the poll, at least the way they ask it, 75% argued that VAE should be allowed, and a lower number argued that physicians should be able to assist in suicide. So, and that might be, again, the broad culture not being careful with the distinction of the terms. That might be why these numbers don't coincide with the views of the distinctions between the two, with Watts and Howell, who suggest that PAS should be allowed, but VAA should not. In any case, they argue that this slippery slope argument that physicians would lose their integrity if they're going to allow to participate in physician-assisted suicide, they allow that argument itself is dubious, that would not, in fact, harm the integrity of caregivers, and instead, they say that it seems inhumane to let people suffer. And an important part of the physician-patient trust is that the physician has a goal of providing comfort. And this would be true, of course, with nurses and other medical staff. They are trained to provide comfort, especially to those who are terminal. And so, as we mentioned before, there's this balance between, training people to fight against death, but we also train our physicians to provide comfort as much as possible and to not allow people to suffer. And so what Watts and Howell are arguing is that this isn't going to undermine the trust of medical professionals, because it's in line with their primary goals of providing comfort to people who are in pain. A final concern that Watts and Howell address is the concern that physician-assisted suicide might weaken societal commitment to providing care for the dying. We saw that Dorflinger was very concerned about this. They argue that even if physician-assisted suicide were accepted and available and legal, that few would end up actually choosing it. It's not going to be pervasive. And they, again, cite studies in the Netherlands that show a small proportion of the terminally ill elect to have voluntary active euthanasia, which is legal in the Netherlands along with physician-assisted suicide. And so they say, in fact, this only a small proportion of people would do it. And since most people would not choose PAS, the overall number of those with terminal illnesses wouldn't decrease, at least it wouldn't decrease much. So we would still have the same obligation to provide for them. The obligation to provide shouldn't change, they argue, just because PAS is available. You still have the majority of people not choosing it. And to withhold PAS from those who do seek it would be to subordinate the interests of the few, those who want to have PAS, for the sake of the many, those who don't. And they argue that that would be violating the rights. This is more of a Kantian type of argument as opposed to a utilitarian type of argument. In conclusion, we have two claims here. First, they say there's no desire to romanticize PAS. There's no desire to encourage it broadly. And we see that with their desire to continue to restrict voluntary active euthanasia. But they argue it should be allowed for those who seek it. And again, they don't expressly provide a Kantian argument, but it seems like a Kantian type argument might be permitted here, unless you are actually Immanuel Kant, who said one should never commit suicide. So, but Kantians in the tradition of Kant argue that, well, if you were in that case of being in terminal condition, consistent and terrible pain with no hope of recovery, you might want to have PAS, so we ought to allow it for others.